Hello everyone. This is about a 77-year-old man admitted in our hospital with cardiac failure. X-ray chest PAV was done in sitting position. To ease the findings, I am also including the CT chest topogram for better interpretation. To those who might not know what is this CT chest topogram, this CT chest topogram image is almost like doing a supine X-ray chest with good penetration. This image of X-ray chest and CT topogram was given as quiz through Google form and asked them about the findings and the probable differential diagnosis. Of the many participants, 3 of them have given the findings and probable differential diagnosis. Congratulations to them. You people are really great. Now we can go with our images. What do you think? It looks like a spotter to exam goers, but not for the practitioners, because the practitioners nowadays do not rely on X-ray chest alone for any cardiac findings and always needs echo most of the times. Sometimes X-ray chest is being done only after echo in some of the hospitals in the background of emergency, and that's right too. There are 3 typical findings in the given X-ray chest and in the CT topogram which should not be missed and never to be forgotten. That's why it's given as quiz. If you have got the findings, you are great. But if you want more time, please pause the video and go back and think. Now I am going to give the findings. Are you ready? Let's go. What are all the 3 findings? First one is significant cardiomegaly with large right heart border, and that's the easiest one. Second one is significant subcarinal widening, means that the angle between the right and left bronchus is usually 45 to 90 degrees in general. But here it is highly eye-catching, especially in the CT topogram. And after that, you can see that in the X-ray chest, you can see the widening of the right and left bronchus below the carina. The third one is the dilated left atrial appendage, which is bulging out, which is difficult one. First and second ones are easy to catch, but the third one is not easy. It becomes easier if we know the basics of the left cardiac border in the X-ray chest. Usually in old adults, aortic knuckle is seen first to the left of spine in the uppermost border of the heart in any X-ray chest, and everybody knows that. Then in normal individuals, there is a blunted area or clear space below the aortic knuckle, which is the contour of undilated main pulmonary artery, which is above the left main bronchus level, right? After this quiz, when you see any X-ray chest, try to see anything bulging below the aortic knuckle. If the bulge is there with cardiomegaly, you might be dealing with dilated pulmonary artery. But other things like enlarged lymph nodes or mediastinal or pericardial cyst or a mediastinal mass might also do that. That's why it's not so sensitive. In old age group, dilated aorta or dilated heart also obscure this angle above the left main bronchus. Okay, just below the pulmonary angle or pulmonary bay, you call it, below the aortic knuckle, there is appendage of left atrium, which is otherwise called as left atrial appendage, which is usually unseen because it is contiguous with left ventricular border level in the X-ray chest. It is seen around or just below the left main bronchus level. Now many of the people might give this question is, what is this left atrial appendage? Major portion of left atrium is in the center, anterior to the bony spine. In addition, there is a thin portion anterior to the main left atrium below the left hilum. It is a minuscule of left atrium and is called as left atrial appendage. In X-ray chest, after this left atrial appendage, there is long left ventricular border, which everybody I think knows. In general, aortic knuckle and left ventricular border are the well visualized ones in X-ray chest more after 50 years. In this X-ray chest and in the CT topogram, the dilated left atrial appendage is so classically seen below the left main bronchus. It's greatly seen in the CT topogram, and then after that you can see in retrospectively, you can catch that in the X-ray chest too if you can see the left main bronchus. In addition, there is either thin atelectatic changes or some pleural effusion or both above the dilated right heart border in the right lung. Again, I'm going to recapture the 3 findings in our X-ray chest and see. One is significant cardiomegaly with large right heart border. Second one is significant subcarinal widening, and the third one is the dilated left atrial appendage. Now we can go for the differentials. The differential for significant subcarinal widening are One is left atrial enlargement, second one is pericardial effusion, the third one is subcarinal lymph node or cyst or mass, and fourth one is mediastinitis or lung fibrosis. Now we are going for the DD, for dilated left atrium, which can be multivalvular heart disease, especially mitral regurgitation with or without mitral stenosis. You think about the age, 77. Second one is prolapsed mitral valve. The third one is papillary muscle dysfunction. And the fourth one is left atrial myxoma. And fifth one is left atrial aneurysm. With our X-ray chest and CT topogram, three differentials are still thought of. One is massive left atrial dilatation. The second one is pericardial effusion. And the third one is multivalvular heart disease, especially mitral regurgitation with or without mitral stenosis. Or all these three could be coexistent. Now, what do you need for the confirmation or for the diagnosis? If you think about CT or MR, you are radiology friendly, but it is not right, because echo will almost rule out pericardial effusion and many multivalvular heart diseases. Now I'm going to give the echo image. What do you think? Yes, there is massively dilated left atrium with good color filling. On echo, our cardiologist did not find significant pericardial effusion or any thrombi or papillary muscle dysfunction or mitral valve collapse or any atrial myxoma. But he still wanted CT with contrast to confirm his diagnosis. Now you can please go through the CT images and think about the findings. CT gives the clear pictures of our mindful thoughts. Yes, there is massively dilated left atrium, which is probably ballooning from the left atrial appendage. Now you might think, which is this dilated left atrial appendage I am talking about in this CT? The contrast-filled dilated heart anterior to the descending aorta and is going to the left anteriorly is the dilated left atrial appendage. Rest of the contrast-filled heart anterior to the spine and posterior to the ascending aorta and the main pulmonary artery are the massively dilated main left atrium. You can think about a balloon which is being blown up through its neck, and the neck is the left atrial appendage, which is also significantly dilated here. In this CT, there is no thrombotic filling defects in the left atrium or in the appendage, and this can be actually easily missed on echo. This thrombus in the even in the dilated left atrial appendage can be easily missed on echo when the dilatation, the left atrial dilatation is so much. But that can be picked up by transesophageal echocardiogram, which is a different probe and might not be present in most of the hospitals. Now we'll go for other findings in CT. One is minimal to mild pleural effusion is noted bilaterally with thin pericardial effusion, which is seen only around the right atrium and below the right ventricle. Now we'll go for the differentials. Without echo, the differentials are massive dilatation of left atrium due to resistant or recurrent atrial fibrillation or multivalvular heart diseases, especially with mitral regurgitation with or without mitral stenosis, and lastly left atrial aneurysm. I'll finish the quiz with the clinical background. The patient was not hypertensive till 50 years of age, and then he was hypertensive and treated with one drug for almost 10 years, and after that he was lost for follow-up, and 2 years back he had been admitted in the hospital due to supraventricular tachycardia and had significant mitral regurgitation with cardiac failure. He had been treated with drugs with advice of follow-up. Again, he was last follow-up. Today, he was admitted here with severe hypertension and atrial fibrillation. So, finally, the diagnosis is left atrial aneurysm secondary to severe mitral regurgitation and recurrent arrhythmias. If you think it was informative, give your positive comments in the YouTube channel itself, and please share this with your friends, colleagues, and juniors. I thank you very much for your time. All the best. Take care and bye-bye.